Morning, everyone. Today we'll see interceptive orthodontics. Interceptive orthodontics. Coming to its definition, interceptive orthodontics has been defined as that phase of the science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions of the developing dentofacial complex. Then, coming to introduction, interceptive orthodontics basically refers to measures undertaken to prevent a potential malocclusion from progressing into a more severe one. Some of the procedures carried out in interceptive orthodontics can also be carried out in interceptive orthodontics, but the difference is their timing. Different procedures which are done in interceptive orthodontics are serial extraction, correction of developing frostbite, control of abnormal habits, space regaining, muscle exercise, interception of skeletal malrelation, removal of soft tissue or bony barrier to enable the eruption of unerupted teeth. And coming to serial extraction is usually initiated in the early mixed dentition when one can recognize and anticipate potential irregularities in the dentofacial complex. Serial extraction is corrected by planned extraction of certain deciduous teeth and later a specific permanent teeth in an orderly sequence and determined pattern to guide the erupting permanent teeth into a more favorable position. History of serial extraction. Egelbrun in 1929 used the term serial extraction. He was who started the serial extraction procedure. Then Nance in 1940 popularized the serial extraction technique in the United States of America and termed it as planned and progressive extraction. Holtz in 1970 called such procedure as active supervision of teeth by extraction. The rationale of serial extraction. The serial extraction is based on two principles. The first one is arch length tooth material discrepancy. When there is excess tooth material as compared to arch length, teeth are extracted so that the rest of the teeth occlude normally. And physiology tooth movement. Human dentition shows a physiologic tendency to move toward an extraction space. Selective removal of some teeth will guide the rest of the teeth which are in process of eruption to extraction spaces by natural forces. Indications of serial extraction. Class 1 malocclusion showing harmony between skeletal and muscular systems. Arch length deficiency as compared to material where growth is not enough to overcome the discrepancy between tooth material and basal bone. Patient with straight and pleasing profile. Then what are the contraindications of serial extraction? Class 2 and Class 3 malocclusion with skeletal abnormalities, space dentition, anodontia or oligodontia, open bite and deep bite, midline diastema, Class 1 malocclusion with minimal space deficiency, unerupted malformed teeth, example dilacerations, extensive caries or heavily filled first permanent molars, mild disproportion between arch length and tooth material that can be treated by proximal stripping. Then, Procedures for serial extraction. There are three popular methods of serial extraction. The first one is Wells method, in which deciduous canines are extracted at age of 8 to 9 years. Deciduous first molars are extracted at age of 9 to 10 years. Extraction of erupting first premolar. Then Reed's method. In Reed's method, extraction of deciduous first molar is done at the age of 8 years. Extraction of first premolar and deciduous canine simultaneously. Nance method is similar to Reed's method. What are the advantages of serial extraction? Serial extraction is more physiologic procedure when compared to a conventional orthodontic treatment. The psychological trauma associated with malocclusion can be avoided as we are not letting the malocclusion develop fully and we are intercepting or developing malocclusion into a more normal occlusion. Uh, See, it also eliminates or reduces durations of multi-banded fixed treatment. Better oral hygiene is possible with serial extraction procedures because the appliance time is reduced or eliminated in some cases. Health of investing tissue is preserved as the time of fixed appliance is reduced or eliminated. Lesser retention period is required because we have done the treatment with physiologic tooth movement. More stable result as tooth material and arch length are in harmony. Then what are the disadvantages? It requires clinical judgment, no single approach that can be universally applied to all patients. Treatment time is prolonged, patient cooperation is needed. Though fixed appliance treatment time is reduced, the overall treatment time and number of appointments the patient has to visit dental clinic increases significantly. And patient cooperation is absolute for uh, success of serial extraction. Tendency of developing tongue thrust habit. Buccal tooth extension can result in deepening of bite. The risk of reduction in arch length by nasal migration of buccal segment. Ditching or space can exist between canine and second premolar. The axial inclination of tooth at the at termination of serial extraction procedure may require correction. This necessitates short-term fixed appliance therapy. Then coming to developing anterior crossbite. Anterior crossbite is a condition characterized by reverse overjet, wherein one or more maxillary anterior teeth are in lingual relation to the mandibular teeth. It should be intercepted and treated at an early stage to prevent a minor orthodontic problem from progressing into a major dentofacial anomaly. As an old maximum states, the best time to treat a frostbite is the first time it is seen, or else it may grow into skeletal malaclusion. Then coming to classification of anterior frostbite, can be dentoalveolar anterior frostbite, skeletal anterior frostbite, or functional anterior frostbite. Then uh, these are the pictures of anterior frostbite. Then interception of habit. The correction of anterior frostbite can be done uh, using a removable appliance if it is a single tooth frostbite. When multiple teeth are in frostbite, it is best to go for fixed appliance along with posterior bite plate as per the patient's requirement and cooperation level. Then interception of habit. Habits refers to certain actions involving the teeth and other oral or perioral structures which are repeated often enough by some patients to have a profound and deleterious effect on the positions of teeth and occlusion. And some uh, common oral habits are thumb sucking, tongue thrusting, and mouth breathing. Thumb sucking, most frequently practiced by children, causes damaging effect on dentoalveolar structures. Its present up to 2.5 to 3 year age is considered normal. If thumb sucking persists beyond 3.5 to 4 years, have a damaging effect and should be intercepted. And thumb sucking is intercepted by use of habit breakers that can be renewable or fixed habit breakers. Then coming to tongue thrusting. Tongue thrusting is a condition in which tongue makes contact with any teeth anterior to the molars during swallowing. Deleterious habits can clinically present along with open bite and anterior proclination. Intercepted using habit breakers and trained for correct technique of swallowing. Then mouth breathing. Mouth breathing can be due to obstructive nasal polyps, tumors, inflammations, or deviated septum, or it can be habitual. Persistence of habit after removal of the obstruction is a habitual mouth breathing. Mouth breathing affects the orofacial equilibrium due to lowered mandible and tongue posture and hence causes malocclusion. Intercepted by identifying and removing the causes. If persist, vestibular splint can be used for treating the mouth breathing. These are the habit breakers. In case of thumb sucking, we can use this type of spike, and in case of tongue thrusting, this type of spike are preferred. Then space regaining. Early loss of primary molar and failure to use space maintainers may lead to reduction in arch length by mesial movement of first molars. Space regain by distal movement of the first molar, which is undertaken at an early age prior to eruption of second molar. Commonly used space regainers are Graver space regainer, in which a U-tube and a U-rod is used. A rod is inserted into a tube with activated spring at the free end of the rod. Jack screw split in the acrylic plate with jack screw in relation to eventual space retained using Adam's clasp. Cantilever spring. Removable appliances that incorporate simple finger springs can also be used for regaining the space. This is a Graeber's space regainer in which a U-tube and a U-rod is used uh, and a spring is placed at the free end of U-rod which helps to regain the lost space. This is a space regainer with jack screw which is retained using Adam's clasp. The screw is activated which will apply the force on the teeth and regain the lost space. This is a space regainer using uh, ca- cantilever spring. Interception of skeletal malrelations. Interception of class 2 malocclusion. Class 2 malocclusion occurs either because of the excessive growth of the maxilla or uh, deficient or small mandible than normal or combination of both. When class 2 is due to excess maxillary growth, we can restrict the growth of maxilla by using face bow with headgear. When there is deficient mandibular growth leading to class 2 malocclusion, we can use appropriate myofunctional appliance in order to enhance the growth of mandibula and correct the class 2 to class 1. And if the etiology for class 2 is combination of excessive maxillary growth and deficient mandibular growth, we can do the correction by using phase bow to restrict the maxillary growth and myofunctional appliance to enhance the mandibular growth. Then interception of class 3 malocclusion. When class 3 malocclusion is due to mandibular prognathism, a chin cup with headgear can be beneficial in order to reduce the severity of class 3 malocclusion or uh, bring it to the class 1. If the class 3 is due to maxillary retrognathism, a face mask therapy to enhance the growth of maxilla can be used to reduce the severity of class 3 or to correct it to class 1. And when class 3 is due to the combination of these two, we can use both of them to reduce the severity or to correct the malocclusion. Uh, Here we can see a chin cup petit type of face bow, which consists of chin cup, face bow, and then removal of soft tissue and bony barriers. Failure of teeth to erupt in appropriate time should be intercepted by surgical exposing the crown. The over-retained primary teeth, ankylosed primary teeth, and supernumerary teeth are possible causes of non-eruption of their succedious teeth. The soft tissue and any bone overlying it are removed. The tissue is removed to that extent such that the greatest diameter of the crown of the tooth is exposed. This completes Interceptive Orthodontics. If you have any doubt, you can come back to us on our department email ID. We'll be happy to answer all your doubts. Thank you.